this week on the BackTable podcast.
Like I said, they bought it for the endo guys, and it happened to be at the surgery center, and I think there was an issue with it. And so I was like, oh, we have the Thulium. I'm like, okay, let's try that. And tried it because I'd heard from some other people that it worked pretty well. And once you go to Thulium, you'll never go back, I don't think. I think it's pretty exceptional. I've talked to some colleagues and they're like, yeah, it's good, just good. And I was like, I don't know what planet you're on. To me, it's the worlds of difference. I think it works exceptionally well for this indication. So I use it for all my upper tracts if I can.
Hello everyone, and welcome back to BackTable Urology Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and BackTable.com. The host is Silva as your host this week. I'm happy to introduce our guest, Dr. Padraic O'Malley. He is currently Associate Professor at the University of Florida Department of Urology and Chief of Urology Oncology. He completed residency at the University of Toronto in Canada. He completed his Urologic Oncology Fellowship at the Weill Cornell Medical College in New York, where he was awarded the Ferdinand C. Valentine Fellowship Award. Padraic, welcome to BackTable.
Hey, thanks for having me. Pleasure to be here.
So Padraic, tell us about your practice. I know you do a lot of cancer. You're the kidney guy, or one of the kidney guys up there in University of Florida in Gainesville. Just go over what you do.
What my day-to-day is.
Exactly.
So I do a lot of bladder and quite a bit of upper tract urothelial carcinoma, as well as a lot of renal cell and some testicular. And I try and do as little prostate as possible.
So Padraic, early 2023, finally there was guidelines for upper tract urothelial carcinoma, right?
Yeah. I think it was long overdue. And I think a lot of people were happy to see that.
Yeah, we had other type of cancer, but urothelial upper tract seemed forgotten. Finally, they came in. So let's talk about, you probably get a lot of referrals, but what's the initial presentation or usual presentation of these patients?
Yeah, so being a referral center, a lot of patients we see, many can be sent in. But usually, these patients are patients who've had upper tract imaging, most of them for gross hematuria or workups for microscopic hematuria. So most, certainly in the United States, seem to have CT scans with contrast. We'll see how that changes over time because the microscopic hematuria guidelines have changed a bit, which I think for good reasons. But most patients, it's usually on evaluation for those causes that they present and are found to have these issues.
Exactly. You mentioned microhematuria, and I don't want to go into that, but definitely I think we were already doing cystoscopies in those patients.
Yeah, I think we overdid our cystoscopies. I think we overdid CT imaging as well. I think many other places that are sort of look at sort of cost for the value of care you get. Some nice imaging modeling studies done by Jim Hugh, for example, looking at how much benefit is there to do a CT scan over an ultrasound in some of these patients. And in the grand scheme, there really wasn't much. So I think we being a little bit more judicious in who we use those imaging modalities in, which I think overall is a good thing.
So you will expect if you have a thesis, urothelial carcinoma in the ureter, there might be some hydro. So you're going to pick it up with the ultrasound, then maybe do more imaging for that patient.
Yeah. The vast majority of patients who have significant issues are going to have obvious signs, even if you have a non-contrast image or even if it's a CT, but it's not gotten, a urogram or delayed phase. Most of the ones that you're really worried about, you're going to see, not always, but most of them.
And what about a cystoscopy? Are you doing cystoscopy in all the patients with upper tract cancer?
Yeah. Any patient gets referred in to me for bladder cancer or upper tract, irregardless of if they've had a TURBT or uteroscopy, they all get cystoed when they come to see me. It's just, I think, if you're going to treat someone for upper tract, you got to know what the status of their bladder is beforehand. So you manage it confidently and there's no surprises. And so all those patients, I think you just have to scope them all.
And patients that for some reason they cannot get contrast, are you doing imaging versus what other type of imaging are you doing? Or are you going straight into ureteroscopy in this type of patients that cannot get contrast?
Yeah, so the ones who can't get CT contrast, there's been some recent data on contrast-induced nephropathy and how the risk has probably been overplayed. So I think we can be a little bit more forgiving in who we give contrast to in that sense. And then you've got also with MRIs with the third and fourth gadolinium agents, you can get down to almost the level where the patients are on dialysis instead of giving contrast. So I think that fixes a lot of the issues there. There are obviously some differences when interpreting MR urograms versus a CT urogram. You have to be a little bit mindful of that. And then, there's always the reliable retrograde pyelograms. That in combination with an ultrasound or a non-con CT is usually pretty good and robust to look at the upper tracts in those patients that can get, the contrasted CT or contrasted MRI.
And in a patient that can get both, do you do the classic CTU or are you doing more MRIs?
Yeah, I would do the classic CTU. It's easier, quicker, probably cheaper. And a lot of patients may not have a baseline anxiety or claustrophobia, but you put them in an MRI and it seems to come out in a lot more people than you'd suspect.
True that. Let's talk about urine cytology. Are you doing it on every patient with possible upper tract malignancy? Who do you order urine cytology?
So that depends on what you mean in sense of, if a patient, like I said, comes in to me, they're going to get a cysto in the office, they automatically get a urine cytology. I usually don't do a void. I'll just do it at the time I do the cysto. And you can argue that one's better than the other, but that's debatable. I just do what's ease of workflow. If you're taking them to the OR, if they've had a negative cytology and you're convinced this is some high risk, then usually if you're going to go evaluate, say, the right collecting system, because that's where the mass is, I will usually do a selective ureteric washing from that side. And I usually do that with like a 5 French open-ended catheter, and I'll instill a saline as I run the catheter up the ureter, and then I'll aspirate as I come back down. So it's almost like, even by running that 5 French up, you're almost barbitaging the ureter. So I find that works pretty well.
And do you see discrepancy between just the regular post-void urine versus that barbotage?
You can, yeah. I have seen that. Yeah. And the data would suggest that you have an improved yield with the barbotage and less risk for sort of contamination, prostatic urethral contamination, by using the open-ended catheter and doing the upper tract washing. How clinically significant is it going to be? I think that's a little more debatable. But usually, I just do that as sort of standard practice. If I'm going to do a uteroscopy, they're going to get a urine cytology from that side. And oftentimes, if someone's got, positive void cytology, but a negative cysto, they're going to get bilateral washings and stuff like that.
And in those patients that do get positive and you don't find anything, what happens when you don't have a gross mass or something like that?
Yeah, so you're saying it's the case where you go in and you want to say, look at one side of the one collecting system and you do a washing and you go up and you look in there and you don't find anything, but your cytology comes back as positive.
Yeah.
I generally tend to risk stratify those patients. So, if they've got heavy smoking history, if they fit the bill, then I'm going to probably keep a closer eye on them. There's reasonable data for things like blue light and stuff like that in the bladder and the lower tract. But even that said, there's some recent studies, the recent one in England that showed that, blue light didn't make as big of a difference as maybe we first thought. So most times I think if you really did a good job of looking and it comes back negative, you just sort of probably have to consider repeating the evaluation down the road, 6 to 12 weeks or something like that, and just seeing if anything pops up and just have a high index of suspicion and be a little bit cautious in those patients.
So every 3 months, do something. You will do imaging as well, or just going in and take a look?
If I'm suspicious, they might get repeat imaging. But if I'm going to go take a look myself anyways, they probably don't need the imaging as well. And I would do it at 3 months. And if it's negative, then I push it out further to 6 months. You're not going to take that person to the OR for uroscopy every 3 months for the rest of their life. So you start pushing it out as you get further out. And if the repeat cytologies are negative, then I think you feel more confident in that.
And in patients that you have a positive cytology, a positive CAT scan with a mass in the kidney or in the ureter, how important is going in and getting a biopsy?
I think it depends on who you ask.
Okay.
And what country they practice in. So, the AUA guidelines are very US-centric, right? And so I don't think they're really medical legal reasons for it. I think it's just the usual way of practicing to have a biopsy. If you look elsewhere in the world, like in Canada and in Europe, I don't know actually in South America, but I imagine it's the same. It's that, if it looks like a duck, quacks like a duck, walks like a duck, it's probably a duck. And there is good data. There was a meta-analysis done that showed that I think in 8 out of 12 studies looking at this, there was an increase in bladder recurrences in those patients who had a biopsy prior to nephro-U. So, it's not without its own costs. And sometimes with some of these patients, you get rid of their upper tract disease and it's great. And the thing that ends up being a pain is the recurrences in the bladder. So anything you do that increase that risk, if you didn't really need to do it, does it change your management? Probably not. So are we just doing extra work for no reason? And it also potentially delays them getting to the surgery that they really need. So I have a bit more leniency in that. I will tell you most of my partners would say absolutely biopsy first. And then it comes down to as well as if you're someone who believes in neoadjuvant chemo for those patients, is your medical oncologist going to treat just the cytology, or are they going to want a biopsy as well? And that varies, I think, from place to place.
Yeah, I guess, I mean, if it's not going to change when I train in Puerto Rico, if it's not going to change the type of surgery that you're going to do, maybe, like you mentioned, do you really need a delay, a definite treatment of this patient?
Well, I mean, it's very interesting to me that the AUA guidelines on this say, oh, we should do a biopsy in this setting. And 85% of the time, it's diagnostic when you do a biopsy. But most of these cases, you already know what it is without doing a biopsy, right? But then when it comes to small renal masses and renal cell carcinomas, the diagnostic yield of a biopsy is much higher. The risk of it being a non-RCC is actually much higher. So, 20, 25% small renal masses. And yet we're not mandating that on guidelines. So there's some discrepancy there between the two sort of guidelines and how people approach things.
Good to know. So, Padraic, what about Lynch syndrome? What do we need to know, or when do we need to think about this as being part of it, and does it matter in terms of that specific patient?
Yeah, so I think maybe I would say 7 to 10 years prior to now, Lynch syndrome was like, okay, be aware of this if they have a colon cancer kind of thing. And it would show up on a board exam or that sort of thing. The reality is it's far more common than we probably suspected. And, there are estimates, it's like 7 to 20% of cases are actually potentially Lynch syndrome. So I think in the last couple of years, 3 or 4 years in particular, there's been a much bigger awareness of this, both from the urologist point of view, the medical oncologist, and especially the pathologist as well. So I think we're a lot more in tune to realizing that, hey, this is something we should really keep in mind. Traditionally, the presenting age for these patients with Lynch syndrome is probably 10 years younger on average than most upper tracts. Generally speaking, upper tracts is more male than female. It's probably a little more equivalent in Lynch syndrome. We all know sort of the colorectal association with Lynch syndrome, probably less aware of sort of ovarian, endometrial, but there's, the whole list of malignancies that go with Lynch syndrome. So I think we're a little bit more robust in our screening of what familial diseases patients' families may have. And then the pathologists are doing routine histological testing. It's not as sensitive, germline testing and things like that, but it has been shown obviously to be more accurate than clinical history. So I think our pathologists are doing us a big favor by helping us pick these up more readily. And if we forget, they certainly don't. So it's becoming a much bigger aspect of our upper tract patient sort of disease management.
And in those patients that, let's say, they already diagnosed with colon cancer, for example, and the family high history, what aggressive measures will you do in this patient? I mean, will you go in and do barbotage on each side, or just urine cytology, imaging?
Yeah, I think that there are starting to be better sort of guidelines on this, and even some are becoming more sort of risk adapted based on the mutation that the patient may have. Most of these will involve cytology and upper tract imaging, and then the frequency of those can sometimes get dictated based on the mutation for that patient. But those are sort of baseline, the cytology and the upper tract imaging.
And you mentioned the mutation. I mean, there are ones that are more aggressive. In those cases, you will do it every 6 months versus a year.
Yeah, so they are more frequent to start with. And the best source for those guidelines, because I always look it up depending on the things, is probably the CDC has some available for health professionals, and there are some NIH ones that have been published. But usually, yeah, if it's sort of the more aggressive variant or has a higher rate of incidence of upper tract, then you may sort of modify your imaging and the frequency of that based on that.
And I asked you before, but is there any difference between CTU and MRU in these patients?
So then, that's comes into sort of, I think, a lot of things with surveillance is cost, but also, radiation exposure, right? So patients are presenting at younger ages than most upper tract patients. The LARA guidelines would say as low as reasonably allowable. So if you can decrease the amount of radiation by alternating with other imaging modalities, MRI or even ultrasound, is probably not unreasonable. I don't think you have to worry about it because of kidney function most times, unless they've had a prior upper tract, but it's not unreasonable to consider the MRI to decrease the radiation. But at the same time, most patients that age, that's probably not going to make a massive difference.
And let's discuss risk stratification in these patients. You have the low risk, high risk, unfavorable. How does each stratification changes, and what are the options to these patients?
Yeah, so it's kind of like going from a nephron-sparing approach to more radical treatments, possibly with systemic therapy, right? That's the sort of spectrum of therapies. And it's dictated initially by the grade of the biopsy, so low grade, high grade, and that puts you into low risk, high risk, and then favorable and unfavorable. And those sort of risk stratifications, the favorable, unfavorable, are sort of based on, they're multifactorial. They're based on, the cytologies, the imaging findings, even the ureteroscopic appearance, as well as, is the bladder involved? And so when you start having, multifocal lesions, evidence of obstruction on imaging, large nodes, right, that obviously shifts you from favorable to more unfavorable side of the spectrum. So there's this risk stratification that's basically initially based on grade, and then the subsequent favorable, unfavorable is based on those other factors that we routinely have for these patients.
And for example, tumor ablation. Who is a candidate for tumor ablation?
So in the guidelines, the ideal patients for these are going to be the low risk, the favorable low risk patients, right? Those are the ideal candidates for this. But it's not unreasonable, and they say, can be offered in sort of unfavorable low-risk patients and in rare cases of high-risk patients, right? And those would be sort of the more potentially imperative indications. So solitary kidney, but, you got a unifocal high-grade mass. Maybe it's reasonable to try an ablative treatment up front if you think you can render them disease-free and save that kidney. So the ablation treatments are considered in the guidelines for those patients. But again, as you move along that spectrum, there's more and more sort of caveats as to why you may or may not want to consider that.
And in those patients that you might consider a tumor ablation, will you do the biopsy first, or sometimes you will do it at the same time and do the ablation at the same time?
Well, that's the thing, right? The stratification is based on the biopsy. So technically you can't, because you won't have your biopsy result. That said, you're not going to put someone through 2 anesthetics like that back to back, just because if you're there, most people are going to treat it at that time if they think it is reasonable. And that, I think, comes a bit with experience and just sort of getting a sense of which ones look low grade, which ones look high grade. Is it multifocal? Is it single? You do most times have the upper tract imaging beforehand. So that oftentimes will help you ahead of time to know who you're more likely to do what in before you get in there.
And in terms of the technique per se, when you're ablating a tumor, are you using laser? Are you going into the kidney and do a resection, like a PCNL? What does it entail?
All of the above.
Okay.
So the guidelines say, whether you do antegrade or retrograde, both are reasonable. I think just convenience, we do retrograde most often. That said, I've had some patients who have bulkier disease and have imperative indications where they're like, I'm not having my kidney taken out and going to dialysis because it's my only kidney. And that's a difficult situation, particularly if they're younger, because those patients will say, look, if you get your kidney taken out, you're on dialysis for a couple of years and then you can get a transplant. And that's the best from an oncological perspective, but it does mean being on dialysis. Now, if you're in your mid-late 70s and I tell you that, you'd be like, why would I go on dialysis till I'm 80? Who's going to give me a kidney then? And it's like, well, that's fair enough. But those bulkier tumors sometimes, depending on the location, if you are comfortable or you have a radiologist that you can get your access. I usually do my own access for those, but you can get that stick in, get your sheath in, and then you can put the TUR resectoscope in there. You can do some nice work pretty quickly that way. I have one gentleman that I've done that a couple of years ago, and I don't know how he hasn't progressed or had it recur, but he's done extremely well with that. So it can be a nice technique in select patients. Most patients you can access at retrograde. And if it's that big that you're not going to clean it all out, then you probably should have been thinking about taking a whole kidney in the first place.
And in those patients that you do the antegrade, can you contrast? I have never seen one and I haven't done it, but can you contrast doing a resection in the bladder versus the kidney in terms of what are you looking for when you're shaving the lining?
Yeah, perforating the renal pelvis is not a small thing to occur, right? And that's a pretty major issue if that happens. And it's not thick like the bladder. So you have to be a lot more cautious about it. I remember Indy Gill was one time a visiting professor in Toronto. He said, sometimes you just have to widen your stance a bit. But you've got to be prepared to deal with the issues. But like I said, you can get a lot more tumor cleaned out very quickly that way. But you do have to be cautious. It's not like doing a TURBT.
So you basically try to shave as smooth as possible and then cauterize whatever's left?
Yeah, so it depends where it's located. If it's on the renal pelvis, on the medial aspect, you got to be very close and you got to be very careful because you can shave it off, but you really can't go deeper. If it's more on the kidney side, you can go deeper, but you can also hit some bigger blood vessels if you're on that side. So there's no free shots. But this gentleman I had, he was more sort of on the parenchymal side. And so, I was able to get a little deeper in that. But again, you got to be mindful of what you're getting yourself into.
And then when you do all these procedures, including biopsy, stent versus no stent.
So in that case where I basically didn't go up his ureter or actually put anything down his ureter. So when I do my perc access, I don't necessarily put anything down the ureter itself, just into the renal pelvis and then get your sheath in. So I didn't leave him with a stent, and I didn't leave him with a nephrostomy tube either. So it's tubeless for him. So that's nice. If you go down the ureter, then I'd be more inclined certainly to leave a stent. When I do retrogrades, unless it's a simple diagnostic ureteroscopy, I look up and say, yeah, look, it's a big fat tumor and the kidney needs to come out. If I'm going to do an ablation, I almost always will put an access sheath within the kidney, just for a couple of reasons. One is access, but also decreasing the risk of bladder seeding. And then when I do that, I'll usually leave a stent. Ideally, I like to leave a stent with a string so the patient can take it out, 3 to 5 days after the procedure. It's just less time it's in there, so it's less discomfort for the patient. It's less time of exposure for the bladder to have seeding. And then, if you do need nephro-U, those are far easier done when patients don't have stents in.
Let me ask you, I'm going to switch the topic a little bit, but just a quick question. When tumor in the bladder at the UO, if you have to resect the UO, do you leave a stent or not necessarily?
No, never. The only time I would is there are some where you get close to probably disarticulating the ureter. And if I get close to that, I'll leave a stent to shore it up. But most times, if it's just really you're a little ways into that intramural portion, I wouldn't leave a stent. And I would say, I don't recall, I'm sure it's happened. It's a perfect selective memory of an oncologist, but I don't recall, having a problem in a patient where I didn't leave a stent like that.
Even if the angle at the end, because sometimes the UO changes the angle, and then should I leave it at?
Yeah, I still don't, and it's yet to bite me in the rear, but I'm sure someday it will. But yeah, I know I don't, because there's lots of patients who have like J-hooking on the ureters because of, a big prostate or something like that. And they don't normally have a problem, right? And it's like, I know a lot of people when they do cystectomies and they do intracardial diversions, they always trim the ureters because they're worried about them kinking, but they never kink. People get hydro and then the proximal portion gets dilated, but it never kinks off where it blocks off higher because of tortuosity or something. So, I think the ureters are pretty good in that sense that unless you disarticulate it, you're not going to have a problem.
Okay, so Padraic, we talk about tumor ablation. So what are other options for low-grade tumors in terms of, for example, there's the JELMYTO. Can you talk about that a little bit?
Yeah, so I think intracavitary sort of therapies have been around obviously for a while with both mitomycin and BCG. And how you give them sort of has been debated. People would put a stent in, then they put it in the bladder and they say, oh, it refluxes up, which to be honest, I think was always wishful thinking. And vast majority of people, I don't think that really works. And I think data would say it doesn't work either. So that meant you could either put it up there with a ureteric catheter or you could put it into a nephrostomy tube. But then the problem you run into is the dwell time, and the dwell time is just not sufficient. So along comes sort of JELMYTO, and it's the sort of reverse thermal gel. And so that basically, it's liquid at that cold temperature. And as soon as it sort of gets to room temperature into the body, it sort of becomes that semi-solid gel. And so it coats the inside of the collecting system, forms almost like a soft cast on the inside. And then you get chemoablation where you can actually ablate. You don't even have to resect the whole tumor. And in the Olympus trial, not all patients had their tumors completely resected, but because of the reverse thermal gel properties, over time, when the urine comes in contact with it, it sort of breaks it down to liquid again, and then it dissolves out and you pass it through the collecting system. So it's a way of basically keeping the mitomycin there longer and creating, I think, a better coating effect. It's a very smart idea, I think. And I think in certain cases works very well. I've used it in a number of patients. In some patients, it's worked really well. In some patients, it doesn't work as well. Why that is a little hard to predict. In the trial, I think almost exclusively it was administered retrograde. In practice now, almost exclusively it's administered antegrade. I think just for most people's workflow, it's much easier. I think anecdotally, people find there's less risk for sort of ureteric obstruction when you give it antegrade. There is a registry, a post-trial registry that is going on that will sort of look at that a bit more closely. And it's indicated for low-grade disease. That said, there is a publication, and I forget who the first author on it is. I know Wade Sexton at Moffitt was on it, and I think Katie Murray as well. But basically, this was in patients who had sort of imperative indications even for high-risk disease. So they give it to some high-grade patients. So, people say, oh, it's only for low-grade. If you look at high-grade patients, those intracavitary agents, BCG and mitomycin, have been used before. There's a meta-analysis that show, the TAT1 on biopsy, upper tract high-grade disease, if you use mitomycin or BCG, they're both equivalent. It's hard to imagine that JELMYTO, the thermal gel, is going to be worse than regular mitomycin, which is equivalent to BCG. So I think, if anything, it may be better. Whether or not it's good enough, probably not in patients who can afford to have their kidney taken out. But in those patients that really don't want to go on dialysis, it may be an option. We'll see. There's no data to support that yet. So that's something I think that's a work in progress.
And you mentioned the antegrade form of treatment. So you have these patients have a nephrostomy, you shoot it in, plug it until next week.
Yeah. So you shoot it and plug it up. At our center, they get the nephrostomy tube put in by the radiologist. And then I think it's about the next week they come back and they get the measurement done. So they get a antegrade nephrostogram. We measure it and then we basically administer the first dose. I always tell them that'll be the longest visit they'll have. And it's still, really 10 minutes at most. And then when they come back for the subsequent treatments, they always seem kind of amazed, like, that's it. And you're like, yep, that's it. So it's very easy to administer that way. It's much easier than trying to put in a cystoscope and then a 5 French up there. And then with the timing of this stuff will solidify in you pretty quick. So I think it's far easier for us and patients. And as I said, anecdotally, I think people are finding they have less issue with the transient sort of obstruction and things like that.
And what other options do a patient with low-grade tumor have?
So we talked about the ablation, both with laser or chemo. One thing I would say with the laser is, there's different laser types. I have no conflicts of interest in this. I have no funding or anything like that related to the different laser companies, but I do like the Thulium for these. At our center, we basically got one for the stone guys, and now the Uro-onc guys don't want to give it up because it works extremely well. I find it's just much easier from my point of view. The other option is you can do a nephro-U, especially if you have multifocal, high-volume disease. That's not unreasonable. There certainly are patients that works very effective. And you can have segmental uretectomies. It's not unreasonable as well. And then if you have, older, frail patients, there is a subset of these lower grade, lower risk, sort of superficial diseases that, realistically, if you did nothing, they're actually not going to progress or go on to cause the patient much problems. So, I think in both guidelines, both the AUA and the EAU, I think you can do observation in select cases. And that's not unreasonable. It's hard to know which are the right patients for that sometimes. So, for instance, I have a lady, she's 75. She was on 5 liters of oxygen at home. She had upper tract urothelial disease, was seen not even in the same state, was given radiation because she was told, look, you can't be operated on, you're too sick. She had radiation. And 2 years later, she's living in Florida, and she basically, her entire upper tract was just full of tumor on the one side, and her bladder was half full of tumor as well. So I took everything out of her bladder, and then I took her and did a nephro-U on her because I didn't think she was too sick to have the surgery done. And, the most noticeable difference afterwards was that she was on less oxygen afterwards, and she's like, I feel great. This is the best I've felt in 5 years. Like, okay. But that's one person says, oh, this person shouldn't have surgery. They're way too sick. And another person says, yeah, look, it's not a problem. So that's difficult to sort of really say who's the right candidate for that. And that's a lot of sort of shared decision making. But no doubt there are some patients that probably is the right thing to do.
So high volume disease will be one of those patients that for you, even if it's low risk.
Yeah. I mean, if the whole thing's just chock full of tumor, it's only a matter of time before that becomes high grade and becomes a bigger problem, probably. Yeah, and then you can imagine in those patients, what are you going to do? Laser their entire kidney and ureter and then give them chemoablation, and then it's going to come back anyways. So.
And right now, what's your workflow or your algorithm in terms of low-grade tumors?
Yeah, so most low-grade patients, they come in, you don't necessarily know the low-grade, but you have suspicions for some of them. You do the uroscopy you do your washing, and then you do a retrograde, and then you do a complete pan uroscopy with a flexible. And then if it's just in the one area, then I'll put an access sheath in. I'll treat that after I take a biopsy. Most times I like to use the stone baskets for the biopsy. It's, classically a big problem with upper tract is getting a good biopsy. But I think there are ways, if you have an access sheath in, I like to use the stone basket and to basically avulse it off and not shear it in the scope, but shear it off just with the basket. And you can get some pretty good specimens like that. Basically, when you take it out, if you don't see it readily, you don't have enough. So, sometimes you'll have to go and get more. There are some flat sessile lesions. Those are harder. Then you're going to need to get something like a piranha that can bite into the tissue a bit more. But a lot of these sort of big frondular ones, you get a big basket, you can pull off a chunk of that. It means less to ablate afterwards. And then I ablate them usually with a thulium, and then I'll leave a stent. I'll give them a single dose of gemcitabine post-op in the bladder, and then I'll have them take the stent out 3 to 5 days later, and then I'll come back and review the pathology. If it's low grade, then we say, okay, look, we'll go and take another look in 3 months and see. If they're clear at that point, then we just watch them with a combination of imaging and repeat ureteroscopy. If it comes back at 3 months, we'll retreat them, but then we'll offer them sort of JELMYTO afterwards.
And the GemSAR in the bladder afterwards is just for prevention, any seedings in the bladder.
Yeah, exactly. Yeah. I think the longer people treat your upper tract, they realize that sometimes the lower tract recurrences tend to be more of a nuisance than anything else in treating these patients.
Again, I'm going to ask a little bit about the bladder. Are you using GemSAR also in patients with low-risk cancer?
Yeah. And when low risk, even the high risk patients, because you don't know until you get the pathology back. So you just kind of like a TURBT, you can give it to pretty much anyone. And, with the gemcitabine too, I think compared to the classic mitomycin, I think it's even easier. It's cheaper, lower side effect profile, works better. So I'm a big fan of it. We use it actually at the time of NephroU. So, there's the Audit C trial where they gave it sort of 2 weeks out. I usually, on my NephroUs, take the catheter out at post-update 2 or 3. So we give it actually at the time of the OR, time of surgery. And that way, when they leave the hospital, they don't have any catheters or drains or anything like that.
Cool. Good to know. I'm going to start using that. And talking about the Thulium, why do you make the change? I mean, you saw it was less bleeding. It was just faster. What made you change?
Like I said, they bought it for the endo guys, and it happened to be at the surgery center. And I think there was an issue with it. And so I was like, oh, we have the Thulium. I'm like, okay, let's try that. And tried it because I'd heard from some other people that it worked pretty well. And once you go to Thulium, you'll never go back, I don't think. I think it's pretty exceptional. I've talked to some colleagues and they're like, yeah, it's good, just good. And I was like, I don't know what planet you're on. To me, it's the worlds of difference. I think it works exceptionally well for this indication. So I use it for all my upper tracts if I can.
And Padraic, so let's talk about the high grades. So for patients with high grades, what are the options?
So everyone is trying to preserve renal function, I think, more and more. And I think rightly so. That said, there are limitations, right? So, big tumors, multifocal high grade, nodal disease, probably no role for it in those cases. I think very selective, unifocal, papillary, probably not in the aorta, but more so in the kidney. I think there are rare select cases where ablation can make sense. And certainly that's the guideline stance as well. But the vast majority of patients with high-grade disease probably do not have unifocal, probably do not have a less than 1.5 centimeter type tumor, those sorts of things. So most patients aren't going to fit the criteria for that. What I do see a lot more of is, and probably because the center we're at, I see a lot of patients who have solitary kidneys, either functional or they've had a kidney removed for another reason. And so then it's like a question of dialysis or kidney sparing. And that's, like I said before, that's a little harder of a movable point for them, right? If you're 75 and you're going to go on dialysis, you're going to be on dialysis. And the healthcare outcomes of patients that age who are not healthy to begin with on dialysis are not fantastic. So, are you losing a lot if you can effectively treat them with kidney sparing surgery? Maybe not. But again, it's a sort of shared decision making. I tell them, look, from a cancer point of view, your best option is having your kidney removed. And I said, but, I get that you may not want to be on dialysis. I usually talk to them also about the benefits of peritoneal dialysis over hemodialysis too. And, the long-term health outcomes are better with that. So sometimes in those patients, when we do the NephroU, we'll actually have the PD catheter placed at the same time through one of the port sites kind of. It gets tunneled, but, it's just one less thing, one less barrier for them to get onto PD versus hemodialysis. But again, those patients who don't want to go on dialysis, I will treat them with the Thulium endoscopically. 6 to 12 weeks later, I'll bring them back and I'll repeat treat them a second time. Even if I think, hey, I did a great job the first time around, there's no way there's anything going to be left. I still go back in and I still retreat them. And then I will give them intracavitary therapies.
And is there a patient that, assuming that they can go safely on nephro, is there a patient that you will do a segmental uterectomy or resection in a high-grade patient?
Yeah, if they've got distal disease, so, bottom third of the ureter, good bladder, that's debatable. I've done patients who have had prostate radiation before and they can be fine. And so those patients, particularly if they're older and have some mild renal impairment, it's a good option, right? The oncological outcomes for a distal segmental uterectomy versus nephro are fairly comparable, if not equivalent. And so, you can spare them that kidney. I do counsel them that they are going to need probably closer monitoring as far as their upper tract and cystos than, if they had the whole thing out. They're also going to have a stent, which they're going to need to have taken out down the road. And they're also going to have a cath left in longer after. If you do a bore flap, I'll leave the catheter usually at least a week anyways, in most cases.
But if you're preserving the kidney, right?
Yeah. For those patients, I would say if you gave them the choice, most of them will say, hey, yes, I'll take the distal uterectomy and keep my kidney. Yeah.
And how important is the bladder cuff when you're dealing with these patients?
So I think that depends on where you trained to some degree. I will say that, where I trained in Toronto and stuff, it was blasphemy to not take a proper cuff. And I think that's true, right? The data shows it's 30 to 50% recurrence rate in the stump. And it's hard to survey that stump. So I don't think you're doing anyone any favors. I will say when I went into practice, at the institution I was in back in Canada, initially when I went back there, we didn't have a robot. So I did the kidney portion laparoscopic, and I would do a lower midline incision, and I'd do an anterior cystotomy in the form of bladder cuff. Like, you can do it right. Now, when I do them all robotically, I still do a cuff. I obviously don't do an anterior cystotomy, but you still make sure you get enough of that cuff. Particularly the more distal disease, then I'm more likely to take a bigger cuff. And, with the robot, the nice thing is you can zoom in, you can get a nice view of it. Using things like a V-lock, you can get a nice closure. You can test it if you want, although I don't think there's any point in testing them, but I would close them. I don't test them. And then like I said, I take the catheter out post update 2 or 3. And even in older men, it's usually not a problem.
In terms of lymph node dissection, for let's say a low risk pan disease throughout the ureter and the kidney, will you do lymph node dissection or you do it every time you do an FRU?
So that's a good question. If they've got like a solitary low risk type lesion, it'd be unusual to do an FRU for that. So the low risk is probably going to be unfavorable low risk. I do think that many of those patients who have like a big tumor but it's low risk, when you take that out at the time of FRU, there is good data that a large number of those patients are upstaged at the time of FRU. And those ones that are big, bulky, low grade tumors, when you take out the whole thing, you will find high grade in them. And that's what I think the risk of progression recurrence comes from. And so in those cases, I would say if it's high risk, you would do it in lymph node dissection. So just because it's 15, 20% higher grade, you're not going to do it. So I sort of err on the side of doing it. I think when you do these robotically, the paracaval and paraortic dissections are very easy to do without very much morbidity. So I think there is a benefit to it. So yeah, I do them almost any time I do an FRU, I will do a lymph node dissection. Yeah.
And how about neoadjuvant chemotherapy?
So I think we tend to flip-flop a lot on this back and forth. When I was a medical student, way back in the day now, I was fortunate to be involved with some research with Bill Wang at NYU, and I was at MSK as a student at the time. And we looked at that, how many patients were candidates for neoadjuvant chemo before versus after nephro, and, the number that are candidates drops way off. And then, people have argued, well, there's no good evidence for it in the neoadjuvant setting because it's all extrapolated from bladder. And then, PAUC comes out and shows good evidence in the adjuvant setting for both cis and carbo. So, the best evidence is in the adjuvant setting. But, when it comes to urothelial and certainly in bladder cancer, I am a big proponent of neoadjuvant chemo. I'm not a big cystectomy up front guy. I really believe that neoadjuvant chemo and systemic therapy really benefits those patients. So I kind of felt that way for upper tract as well. That said, we have a significant problem, and we've always had this problem of really accurately staging these patients. And, even with imaging modality and biopsy and cytology, we still don't have very accurate ways of doing that. So that's a big problem. So either we need to get better at that, or we need to have less toxic treatments that we can give in the neoadjuvant space. And I think what's going to happen, most of the efforts have been in sort of how do we get better at sort of knowing who's the right person to give neoadjuvant to. But I think what's going to happen is, and you're seeing with the recent presentation at ESMO in the metastatic urothelial setting of immunotherapy and enfortumab, that obviously had remarkable results. Keynote B15 is a study in bladder cancer patients with neoadjuvant gemcis, or I should say perioperative immuno and enfortumab. That closed. I think the last patient was recruited like 4 days ago internationally for that study. So we'll see what the results are. The primary outcome for that, I think, was overall survival. So it's going to be a bit of time before we see that. But I think that's going to change standard management as well. There currently is not a trial that I'm aware of looking at this in upper tract, but I'm sure it will be forthcoming. There was a proposal of a trial to look at this at single center. I think it was Cream Chamey who was going to do it, but that has not started recruiting patients yet. So I think what will end up happening is we'll give them a less toxic treatment with the IO and enfortumab, although certainly the enfortumab, many patients can get side effects from that. But I think that's what we'll start treating people with. And I think we'll start doing it on a more routine basis now than what we used to do.
Do you think that maybe every high-risk patient will get some sort of treatment prior to surgery?
I think when the results on the B15, and I don't know, right? Because, we don't know, but my suspicion is that that's going to be a positive trial. With that, or with someone doing the trial in upper tract, I think we're going to start using that more in the upper tract neoadjuvant or perioperative space. And I think that will push a lot more patients to get treatment beforehand. I currently use it in patients that are younger, healthier, and that I'm suspicious of, right? So I had one gentleman who had a sort of a more bulky distal tumor. And, the fat around the distal ureter was a little strandy. And I was like, you should get neoadjuvant chemo. And he probably had a T3 disease. And then at the time of his nephroureterectomy after getting chemo, he had T0. So his long-term outcome now is probably much better than it may have been if I'd taken it out and it was T3. So I do use it in select patients. It is in the guidelines. So I think you either give neoadjuvant or you give adjuvant, or you pick and choose a bit. I think one of my biggest concerns with giving the adjuvant before is that, many patients can't get cisplatin. And, I will say I was guilty of saying that carboplatin was essentially pixie dust. Now, the POUT trial and there's some other studies that are coming out that show that carbo is probably not as useless as we once maybe considered it. It's actually pretty decent. It's not nearly as weak compared to cisplatin as I think we traditionally have viewed it. So I still think that is effective treatment in patients in the adjuvant setting.
And when you're doing the neoadjuvant, you guys are using mainly the same thing that you're doing for bladder in terms of how many treatments, how many doses?
Yeah, so I think based on the POUT, it was the 4 cycles, sort of like neoadjuvant tradition. I think in bladder, adjuvant therapy was really 6 cycles, but in the POUT, it was 4. So, less toxicity maybe for patients. That was always a good selling point for why to do neoadjuvant in the bladder space, was that you don't have to get 4 instead of 6 cycles. But yeah, we use 4 in the adjuvant setting. If they've had chemo before, then you can also use the immunotherapy in the adjuvant setting too with nivolumab. So, those are all options.
I think we cover mainly most of the guidelines. The last thing that they mention is the follow-up. And I guess it depends on what you decided to do on these patients. So let's talk about the nephroureterectomy. I have a patient that you did a nephroureterectomy. What's going to be the follow-up?
Yeah, so then I will risk stratify them based on their final pathology. So those patients with worse disease who get adjuvant, I still have a tendency for holding on to my patients a bit. I like to make sure that they're doing okay. So I oftentimes will arrange the imaging, and they'll end up getting more chest imaging than someone who has a PT0 in the long term as well. But, if you've got bad disease, I'm going to see you, at 3 months with repeat imaging, including a cysto. And pretty much anytime you see me in the follow-up, you're going to have a cysto when you come in, and keep an eye on the bladder. If you have better pathology, I'm still initially going to see you more frequently, and then over time scale you back a little quicker. But most of the the guidelines, I think, are sort of the same way. They sort of say the follow-up is dictated a bit by your sort of disease.
And for patients that had ablation, do you do ureteroscopies in those patients, or you just go by imaging and cytology?
I alternate a bit, and it depends on which risk group they fell in, right? So the low risk group are going to get less ureteroscopies and less imaging. The higher risk group, obviously, are going to get more. Those high risk patients, I'm probably going to do more ureteroscopies, but they're still going to get imaging as well, because with the low risk patients, the concern or the risk of recurrence is sort of local. right? And so you want to look at the lining of the collecting system. But in the higher risk patients, you have two risks of recurrences or progression locally, but also things like nodal disease and metastatic disease. So, the uroscopy looks very nicely at the collecting system, better than the CT does, but it doesn't look at your nodal disease. So in those higher risk patients, they're going to get both uroscopy and imaging when they see me.
Good. So, Padraic, anything else we missed? I think we covered pretty much everything. And any other comments you want to add? Anything you want to say?
I think one of the things I really liked in the guidelines actually was the standardized reporting. So they had in the guidelines, they have a sort of standardized sort of checklist for how you should report your uroscopic and your endoscopic findings, which I think is good for a number of reasons. One, it makes sure that you do all the things you should do. Two, I think it's a detailed but an efficient way of taking a detailed sort of account of what you dealt with. And that way, if you or a colleague or some other practitioner ever has to sort of scope these patients, they know exactly what they've had done and what the problem was and where it was. And I think from a trials perspective going forward, that will make it much more robust, the data we have in those trials as to, what type of disease these patients truly had. So I like that standardized reporting that they had. And then I do like the sort of the overall risk stratification. I think it's pretty pragmatic as to how to split patients up.
You're in Gainesville. If we want to send patients to you, just go to the website. How do we do that?
Yeah, we have a nurse navigator, Lindsay Roundtree. So she handles all the referrals. Currently now, we have essentially 5 uro-oncologists that deal with upper tract. Li-Ming Su is the chair of the department, so he sees upper tract. Paul Crispin, who many people would know, who's been heavily involved with clinical trials and cooperative group trials and industry trials, and has done some nice work in both bladder and upper tract. He's probably the next most senior person. The reason I came to Gainesville for him, great colleague, great mentor. And then just this summer, Jason Joseph, a former fellow of ours, has come back, got recruited back, and Dr. Tarek Beneder, who is a Canadian from Toronto like me, and then was at Cleveland for his fellowship. He's also joined us. So all 5 of us do upper tract currently. So there's a lot of volume.
So Padraic, thanks for being BackTable. I really enjoyed this talk, and thank you.
Yeah, my pleasure.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devante Delbrun.
Social media and PR by G. Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.